Once again, good afternoon to all. So today we're going to discuss a topic, but an important topic basically in palliative care, ostomy care. So ostomy means what? Normally, our body having some natural orifices are there. According to the our mechanism, body mechanism, for the purpose, some things need to get inside to the body from the environment, and after the mechanism, some of the waste products need to excrete out to the environment. So, for the purpose, normally having some natural orifices are there, but due to some of the disease condition or maybe due to the progression of any disease condition, these natural orifices can't fulfill the need of our body. In that conditions, naturally orifice for the natural orifice, we artificially making or surgically we preparing an opening, permanent basis or the temporary basis. Mainly permanent basis means maybe due to the disease condition, the part of the organ or maybe the organ permanently we removing. So the normal that pathway we can use can lead to the orifice. So we preparing on artificial opening, and that opening will be there till the death of that patient. Temporary basis means maybe due to the disease condition we planning to do one surgery. After the surgery, we need to get give rest for that part of the organ or maybe the part of the body for the time period. So for the time period, need to get the rest. So for that period, we making another opening substitute for the natural orifice. After the time period of the rest, we normally we recreating the normal pathway and normal orifice can fulfill the need. So mainly the ostomies are two types, input ostomy and the output ostomy. Input ostomy means, as I said, body need to get something from the environment to the body for the mechanism. So example, tracheostomy, gastostomy, feeding ileostomy. So output ostomy means after the body mechanism, some things need to excrete as a waste material from the body to the environment. So this colostomy, urostomy, and the ileostomy. So these pictures you can see, first one example for the input ostomy, tracheostomy. Second one is the example for the output ostomy, colostomy. So first of all, we're going to discuss about the colostomy. So colostomy means what? Actually, surgically only we making an opening on the abdomen to divert the colon end internally and to the opening for making the large intestine through which feces and the flatus are excreted. Normally by rectum, the fecal matter and the flatus and the secretions are excreted. But here, due to the disease condition, normal rectal opening can't evacuate the bowel content. So artificially we making or surgically we making an opening on the abdomen. We will divert the colon end internally. We will attach to the abdominal wall. Then that will become the stoma or colostomy. So here simply anatomically we can see the large intestine colon part. According to the position, example ascending part, if we making on colon colostomy means ascending colostomy. Transverse area or descending area or the sigmoid area we making on colostomy means according to the name it will vary. Ascending colostomy, transverse colostomy, descending colostomy, and the sigmoid colostomy. So this one is the actual picture of a stoma colostomy. Last picture one is the stomal appliance, so colostomy bag. Next slide. So this one is the colostomy appliance picture. You can see two type of colostomy bags are there. One piece method and the two piece method. One piece method means first picture you can see bag itself have the adhesive part, that the base plate or the wafer, that part along with the bag. So if attaching that bag around the stomal region, whenever the bag is filling with bowel content, whenever need to evacuate, need to remove the whole bag from the stomal site. Second one is the two-piece method. Two-piece method means face plate or the wafer will be there around the stoma, then bag is separate. So whenever we need to change the bag means only bag need to remove from the wafer or base plate, can attach a new one. So when the base plate losing the adhesiveness around the stomal region, that time only need to remove the base plate. Until that time we can keep the base plate, bag only need to change. That's the difference between one piece method and the two piece method. So this one is the actual picture you can see. First picture you can see on gauge. This one is the measuring gauge. So this measuring gauge you can get along with the colostomy bag and set. So this gauge having different size circles are there. Example 25 millimeter, 35 millimeter, 40 millimeter, like that. Some circles are there. So one patient the stomal size is it will different only. So it will vary. So according to the patient stomal size, we need to select the bag. So here this gauge we can use for getting the proper size. So we need to place this measuring gauge that circle around the stomal region. So when we choosing the size it will not too tight and too loose. So proper accurate size we need to select. It we can consider it example we can consider it maybe the 35 millimeter. Then we need to take 3 to 4 millimeter bigger than the actual size. We need to mark it on the back side of the base plate or the wafer part of the colostomy bag. Then we can mark it. It will become around 37 or 38. Example, I'm telling. Then you can use curved scissor. Curved type of scissor you can use and you can cut according to the stomal size. So why we using curved scissor means if we using straight scissor means in between the cut area the sharp edges will develop. It will cause the disturb the stomal side. So if we using the curved scissor means at pure finishing basis we can cut properly the stomal opening. So it will be there any sharp edges. It will be very smooth and finished side. So it will not affect the stomal region. Next slide. So whenever we seeing on stoma, colostomy or stoma means we need to assess something. First one, stomal edema. So actually the stomal edema, even after the surgery is a normal thing only. Day by day or week by week, it will reduce. Normal on stoma will develop around after the 6 weeks only. Around 6 weeks time needed to become a normal non-edematous on normal stoma. So until that time, the stomal edema is normal only. Next slide. So this one is the stomal prolapse or and the bleeding. Stomal prolapse means normal stoma you already seen just protruded around the on the abdominal wall. Internal colon part will be there. It already attached by surgically. So here it happening, the inside part of the colon, it's also prolapsing outside. It will come outside. So normally it happening due to the prolonged cough, or if the patient is lifting any overweight, means it will cause the stomal prolapse. Already the abdominal wall is already it's open, the muscle layers are all open, so the prolapses happen due to this reason. So mild prolapse means you can insert by using our little finger, but moderate to severe prolapse means we need to get an suggestion or opinion from the surgeon. Then bleeding. Bleeding is happening mainly due to any accidental injury, suppose it's happening, or if the patient is getting any NSIDs or any platelet count decreased level also, the bleeding chance will be there. Or otherwise, no bleeding chance is there. If suppose it while cleaning time, any sweating type, any bleeding spot means also, just sponge we can give, it will subside. Profuse bleeding or more bleeding chance is there means we need to get an opinion from the specialized doctors. Then Parastomal hernia. Parastomal means around the stomal region is the parastomal. Herniation means normal herniation. Here also it's happening due to the normal abdominal wall muscle. Already it's weak, its continuity is lost because of the surgery. So after the stomal preparation inside the abdominal wall, uh, around the stomal opening, some gaps are there, or maybe internal colon part also will stick inside the abdominal region around the stomal side. So through that the herniation may will occur. So the herniation it's mainly occurring that hernia repair surgery also we can do. But after the hernia repair surgery, we need to place an another site for the stop colostomy. So one thing, if one time the herniation is occur means there is another site we choosing means also there is a chance is there. It's a complication only. Next slide. So this one is the retraction. Retraction means already you seen the normal stoma, stomal prolapse also you seen, but here the retraction means it's a inverted inside. Normal stomal site is totally inverted. So here is happening means stomal region only two sides some gaps are there. So here we can use the normal colostomy bag because in a normal colostomy bag, the base plate or the vapor region is flat region only. In this type of retracted cases, if we using means in between the gap, the uh, fecal matter or the secretion from the stoma, it will leak out through the space. So for these type of retracted cases, we using mainly modified convex type of colostomy bag we mainly using. So this type of colostomy bag base plate or the wafer will be in the convex type of base plate will be there. On that we can attach the colostomy bag. So mainly 14%, on for 14% of the colostomy cases, this retraction cases normally reporting. Next slide. So this one is the peristomal reaction. Peristomal means around the stomal region only. This peristomal reaction mainly happening due to the continuous contact on the peristomal region with the fecal matter or the secretion from the colostomy is getting continuous contact means it will cause the stomal reaction. So stomal reaction we can prevent by choosing of proper size of bag. The bag will not be too loose and too tight. If too loose means peristomal region is more visibility or exposing. So on that region, if the fecal matter or the waste material from the stoma is getting contact means it will cause the peristomal reaction. So if any peristomal reaction is there means also we can do the management. Next one. So proper skin care is very important. We need to prevent the skin excoriation. That's the important thing. So for that, we can do proper skin care. Wash the stomal region and the peristomal region also wash with soap and water. After washing, we need to keep the area very clean and very dry. After drying, we can fix the bag. Use correct size of bag. That's a very important. The peristomal region is very minimally exposed by the bag. So otherwise the area is exposing means getting contact with the secretion or fecal matter from the stoma colostomy site. So use correct size of bag. Then after fixing the bag, whenever the bag is filling with half portion or maximum 3 by 4th portion of bag is filling with fecal matter, at that time we need to empty the bag, or otherwise it will cause the overflow of the bag. That overflowed that fecal matter or the secretion, it will get contact with the peristomal region. So that's the important thing. 3 by 4th is the maximum quantity. Then for the cleaning purpose, use only the cotton cloths because that's only the skin friendly material. Then these are all the things we can do for the prevention of skin excoriation. If suppose we seeing on patient with colostomy site peristomal excoriation already present means we can do the management as like we can use Karaya powder. Karaya powder means this one is the natural thing only, Karaya plant. From the Karaya plant only Karaya powder we making. This one is the commercially available Karaya powder. So So this karaya powder, we can mix it in the egg white, then mix it very well, and we can apply on the peristomal, that excoriated area. We can apply, leave it for some time for drying. After drying, that area will be on filmy appearance, film coated appearance we can see. Then on that filmy appearance, we can apply the normal colostomy bag. So it will prevent the direct contact on the excoriated skin with the colostomy bag. Then we can apply the barrier cream also. With the colostomy bag, we can get the barrier cream. If it available, is it available means we can use it the barrier cream for applying. Then zinc oxide also we can apply, substitute for the karaya powder for the peristomal skin excoriated area. Then we need to ensure patient need to avoid use of powder or any cream or any deodorants on the area, because for avoiding the smell or for the skin care, for the moisturizing purpose, any cream or powder or anything they are using means it will disturb the peristomal region and the stomal region also. So we need to educate the patient also about that. Next slide. Next. Okay. So according to the diet, after the, if the patient having the colostomy means, we need to take care about the diet. First one, which are all the food items will cause the any gas forming, any food means they need to control. Chili, spicy food they need to control. Then onion, cabbage, garlic, meat, that these type of smell forming food they need to avoid or they need to control. Then diarrhea and constipation is very very important. We need to avoid the situation. So for avoiding the diarrhea, they need to use the same cooking oil for the cooking. So before the surgery, which cooking oil they actually they used to do for the cooking, that the same oil only they need to use, or otherwise in between changing the cooking oil means it will cause the diarrhea. So here the colostomy site having no sphincter control. So if the that patient is affected with the diarrhea means whenever the bowel is moving, that time all the time the bag is filling with the bowel content, fecal matter. So it's a very important. We need to prevent the diarrhea. So as like diarrhea only, the constipation also very very important. So they need to use high fiber, fiber rich diet, and fluid intake also they need to increase. Then we can prevent the constipation. If the patient is having constipation means also it will cause the peristomal prolapse. That stomal prolapse it will cause due to the constipation. So constipation and diarrhea we need to prevent. Next slide. Then traveling time. If the patient is using public transportation system for the traveling means, especially in that transportation system, they need to protect their own stoma with any purse or any handbag. They need to keep. Or otherwise, a crowded situation means other people can't know about the stoma. So accidental injury may will happen. So they need to keep on purse or handbag. Then extra collection, colostomy bag also they need to carry in case of long journey. So if in traveling time, food pattern may will vary. According to that, the quantity and the frequency of bowel opening will vary. So extra bag they need to carry for in between changing. That's all. That time also they need to change. Maximum 3/4. Half portion is safe. Filling with the fecal matter, they need to change the bag. So clothing. In the case of clothing, there is a no restriction with which cloth is comfortable with the patient. But one thing, the clothing material, it will not affect the stomal region. Example, any belt or any tie material they are using means it will not affect the stomal region. That's only. Without affecting stoma, whichever the cloth item the patient is comfortable, they can use. So the sexual life, actually the patient and the family need to get, or they are having the right to get and giving the love and compassion. So for the sexual life, they if they are need to support any advice they need means we can give. Then encouragement and counseling. If any counseling means also we can facilitate to get the counseling and they can continue their life with love and affection. Next slide. So now actually already we cleared about the stomal care and the stomal care. So here we going to see about the back care. So already we told use correct size of bag only. Bag size will not be too tight or too loose. Then empty the bag. Half portion of bag is filled with the fecal matter. We need to empty. Maximize the 3/4 portion. So for the bag care, we can wash the bag by with normal water and soap. Soap and water we can use it for washing. After washing, cleaning the bag, if they need to prevent or control the smell inside the bag means they can put any charcoal pieces, small charcoal pieces they can put inside the colostomy bag. It will act as antioxidant, so it will prevent the foul smell inside the bag. Then after cleaning with the water and soap, then they can dry the bag under the shade or shadow. They can't dry the bag in under the direct sunlight because it will cause the cracks on the bag and it will cause the leakage. So they can dry under the shade. Then avoid, we need to educate the patient and the caregiver, avoid rough brushing or stone washable. They can avoid, or otherwise it will also may will cause the tear of the bag and it will cause the leakage. Next slide. So here on case scenario is there. Anybody can read? Can anybody read this case scenario? Voluntarily, can anyone read the case scenario? One question also there.
Mr. T, 45 years, was diagnosed with carcinoma rectum and had undergone sigmoid colostomy 3 months ago. He has been using disposable colostomy bag for bowel emptying. He is a management executive and finds it very difficult to manage it. Question: what option can you advise him as a palliative doctor nurse?
So here on question is there, as a palliative care doctor or nurse, what option you can suggest for this person? You can put your answer in chat box also. Any suggestion? Any idea, any suggestion you are having means you can put. So actually this person is an executive in between hours or hours having meeting. So in between he can't go to the toilet for changing the bag or evacuating the bag. That's the problem. He know about the changing of the bag, care, everything he know. But due to the tight schedule of his meeting and traveling, because he's an official person, so the in between changing and cleaning is very difficult to him. So any another option as a doctor or as a nurse you can suggest. Any suggestion means you can put. Okay, one answer we go teach the patient and family members. Already taught, he know very well to take care about that. But here the difficult situation is he is not getting adequate time because of the tight schedule of meeting and traveling. And another option, any other option? Use other bags. Okay, using of other bags means whenever the bag is filling with fecal matter half portion, he need to go to toilet and need to change the bag. That thing he know, he is having adequate bag with him. So due to the tight time schedule only, he can't go and change the bag. Okay, thank you for your responses. Here, his diagnosis is the sigmoid colostomy. So, for the sigmoid colostomy only, we can do on management, and another option is there, colostomy irrigation. So, you need. So, only for the sigmoid colostomy, we can do this management, colostomy irrigation. Why only the sigmoid colostomy? Sigmoid region only full formed fecal matter is coming. So we can irrigate completely, we can irrigate or we can clean the colon and we can evacuate complete the fecal matter. So suppose we doing the colostomy irrigation in ascending or transverse or descending area means in that region the bowel content, stool content will be in a fluid or semi-fluid stages. So that region, the colon have the role to absorb needed electrolyte, minerals, and fluid from the stool content. So in that region, we irrigating means it will cause the hypovolemic shock or the profused electrolyte imbalance. That thing, fluid loss also it will happen. So only for the sigmoid colostomy we can give the option colostomy irrigation. So actually colostomy irrigation means what? The irrigation as the word meaning, we completely flushing or completely cleaning or washing or flushing out the total colon with water. That's the colostomy irrigation. Why we need to do the colostomy irrigation? Main purpose, we need to establish a regular bowel habit. Every person having one bowel habits are there. Maybe in morning time, maybe in night time, or maybe two time. So some bowel habits are there for every person. But here, the colostomy region, stomal region, there is no sphincter control. So any habitual formation will not happen on the stomal region. But by using this colostomy irrigation, we can establish on regular bowel habit for that person. Then we completely flushing or completely cleaning or washing the colon with the lukewarm water. So we can clean the colon, gas, mucus, and fecal matter completely from the colon region. Then completely cleaning means in between no bowel content or no stool or no secretion will come through the stomal region. So there is a no chance for getting skin excoriation because there is in between nothing is leaking out. So there is a no chance for getting contact with the peristomal region. So we can prevent the skin excoriation. Mainly we using solution is the plain lukewarm water only we using for the irrigation purpose. Next. So actually here the irrigation, we need to give the instruction to the patient and the family. The irrigation they need to continue lifelong. As like a bowel habit or as like a toileting method, this irrigation also they need to continue till his or her death. Throughout the life period, they need to continue the irrigation. Then habit formation after only after the 21 days. So that thing we need to instruct or otherwise even after starting the irrigation just for 2 weeks or 10 days or after some days they will expect the habit formation. So 21 days needed to get the habit formation. That thing we need to instruct. Then last point, irrigate daily at a fixed time. If the patient convenient time, according to the patient convenient time, is it convenient at morning time means they need to irrigate daily morning in a fixed time. Evening time means evening in a fixed time. So in between one day morning, one day evening, one day afternoon, not like that. Then we can't make the habitual formation. Habitual formation will form if we irrigate daily at a fixed time. So this one is the colostomy irrigation procedure picture. Normally we having on video also. So here picture just I am mentioning about the devices. First picture you can see on colostomy that lukewarm water only we mainly using that water pouring or collection bag is first one bag. Along with the bag on connection tube is there, tube having adjuster on drop flow adjusting on device is there. Then in tip on cone is there. Cone means it not a sharp end, it's a very blunt soft end only cone. This cone only we inserting into the stomal region. Then only after lubricating the cone, we inserting the cone inside the stoma. Then only we using the adjuster for flowing the lukewarm water from the collection bag to the stoma. Then on sleeve also there, mainly the sleeve having belt. With the belt only we fixing the sleeve. Sleeve actually having one inlet and outlet. Inlet means that one opening is there. Through the opening we placing the cone on the stoma. Outlet means through the outlet only the flushed content that after the irrigation the bubble content is coming through the outlet. That sleeve outlet, if suppose patient is sitting in the bathroom means near to the toilet means that tip we can place inside the closet. So for this on video also there we can see. So I think you all seen the colostomy care and the colostomy irrigation. After seeing the video, have any doubt means also you can put it in chat box. So without wasting time, I am just now moving to the example for the input ostomy, tracheostomy. So actually tracheostomy. So tracheostomy is an artificial opening only, making in the tracheal region into which a tube is inserted. Tracheostomy tube is inserted to establish and maintain a patent airway. Normally, if the patient can't use the normal airway for inspiration and expiration, so artificially we making on ostomy on there and we placing the tracheostomy tube. Next slide. So these are all the parts of tracheostomy tube. Normally this one is left side you can see metal type and right side you can see Portex type. So in both type, having three parts are there: outer cannula, inner cannula, and the obturator. I have one question. In this tracheostomy tube, outer cannula or inner cannula, which one have more length, inner or outer? You can put your answer in chat box. Inner cannula or outer cannula? Okay, one answer we got inner. Okay, thank you. It's right. Inner cannula is having more length than the outer cannula. Why? Because the outer cannula will be there on the stomal region and inner cannula only in between we removing and washing, cleaning, washing, and after that drying, we reinserting the inner cannula. So whenever the outer cannula is blocking with the mucus, if we inserting the inner cannula, the tip is comparatively more length, so it will push or it will avoid the blockage of the outer cannula. That's why the inner cannula have more length than the outer cannula. Then obturator in initial stage we using as a gate only on the for the procedure. Next. So tracheostomy, already I told outer tube and inner tube. According to the parts, the management and the care also it will vary. Outer tube will be there on the place with the support of the ribbon or tie. Should not be removed by the patient. Then inner tube only, it will fit inside the outer tube, can be removed for the cleaning purpose. After cleaning, within time limit, we need to reinsert. Then obturator is a guide only for inserting the tracheostomy tube into the trachea. Slide. So for the cleaning for the inner tube, patient only can do or the caregiver. We can train the patient to clean the tube by self with the help of a mirror. Sit in front of a mirror on that support they can remove. Inner tube, thorough cleaning of the inner tube inside and outside under the running water. After cleaning, sterilization, we can do boil it in the 5 to 10 minutes in the boiling water. After that, they can clean with the normal saline. Then they can insert. After the cleaning, zero droplets inside the tube. We need to ensure that after the complete drying only, they can reinsert the inner tube into the outer tube. Then outer tube not to be removed by the patient. Clean the face plate or two plates only they can clean with the saline soaked gauze thoroughly. Tie also can't change by the patient, with the support only can do. Next slide. So here outer tube changing of the tie is very important. With the support only can do. It is applied to fix the tube in position only this tie or ribbon. Change if it is very dirty means they can change. It should not be too after changing the tie. After tightening, it should not be too tight or too loose. One finger gap they need to maintain after tying, because if too tight means it will cause the cuff, and too loose means the chance for it will come out. So changing the tie also, self attempt can't be promoted, only with the support of another person only can change the tie. Next. So here also we need to care about the skin, clean the skin around the tracheostomy tube with the saline soaked gauze. In hospital setting, we mainly using the betadine, but saline only is needed. Soaked gauze they can use it for the cleaning. After cleaning, the keep the area around the tracheostomy tube dry. After drying, Vaseline gauze they can use it for covering the ostomy side, because we can prevent the excoriation. Proper skincare also we can give around the stomal region. Next. So suction and humidification, even after the surgery or even after placing the tracheostomy tube, the suction is frequently need to do. But whenever doing the suctioning of the trachea is done very gently, not more than 5 to 10 seconds, because we need to prevent the hypoxia. So within 10 seconds, one time we need to do the suction and need to remove the suction cap. So humidification also very important. Sterile gauze they can use it after dipping after wetting they can place it the gauze piece on the tracheostomy tube, so it will act as a filter. It will filter the dust and flies, and it will while inhaling the normal atmosphere air, then it will prevent the dryness also. It's a humidification effect also patient will get for at the time of the inspiration. Next slide. So here the along with the tracheostomy tube, the patient normally patient can't speak because the tracheostomy tube is there. But as a part of the speech therapy, they can practice after closing the tracheostomy tube with the one finger. So for that, normally it's a truly the part of the speech therapy only. Take a normal deep breath, then just close the tracheostomy tube with the finger. Then they can practice by spelling one by one word. So according to the breath holding capacity, they can spell the sentence by sentence. So as a part of the speech therapy, they can practice and they can continue the speech even if the patient having the tracheostomy tube also. So here, this also we have on video. You can see the video. So I think you're all seen the tracheostomy care also, the video already seen. Have any doubt in all three videos? Any doubt means you can ask. So, okay, thank you. So now we can move to the case presentation and discussion.
Mr. Percy, over to you.
Yes, sir. Patient details: 40 years, male, diagnosis with colostomy. Presenting complaints: skin irritation, constipation, infection at stoma site, skin necrosis at ostomy site, hernia at colostomy area, foul smell, leakage, and granulomas. History of illness: patient large intestine was blocked due to cancer of large intestine, problem in blood supply of intestine. Part of intestine was removed and ostomy was done in view of patient benefit. On examination, colostomy was done at the right side of the abdomen. Paler and bluish mucosa present at the side. Patient looked with sunken eyes, dehydrated, demotivated, low oral intake, inability to sit properly, unable to sleep and undisturbed sleep pattern, feeling uncomfortable, depressed, anxiety, low self-esteem, and hopelessness. Treatment and significant investigation. A routine investigation to be done. CBC, LFT, RFT, RBS. Treatment to be given: change the pouch regularly, cream apply to reduce the irritation, cleaning of the wound, and maintain hygiene of the ostomy. Psychosocial aspects: give psychological support to the patient and family members, educate about the stoma and its care, motivate the patient. Medications: analgesic if pain is present, plenty of fluids, antacids if acidity is present, antibiotics, antidiuretics, ORS solution, iron supplements, laxative for constipation if present. Main concern is to give palliative care to improve the self-esteem, to prevent from infection, and also to prevent diarrhea and constipation. Thank you.
Sajan, may I ask something?
Okay. Thank you, Sister Bharti. Actually,
Thank you, sir.
actually your concerns to give palliative care to improve self-esteem and to prevent from infection. So actually, the infection is there. Antibiotics is going on. I think
Yes,
so.
sir.
So here the infection actually on the stomal region or peristomal region.
At the stomal region.
Stomal region. Okay. So actually the infection is there means we need to find out the reason. Then only we need to do the management. Correct the correctable only. So
Yes, sir.
due to which reason the infection is there on the ostomy side. Normally the infection or the skin excoriation mainly causing the peristomal region means we first of all already we discussed we need to prevent the excoriation. If suppose any excoriation around the peristomal region means we can do the management with the caraya powder or zinc oxide or barrier cream. We can use it for
Yes,
the
sir.
peristomal region. But here the on the stoma only the infection that reason we need to find out, then do the management. Which antibiotic is going on? It's beneficial for controlling the infection means can continue according to the course basis. So then to improve the self-esteem. So one thing we need to keep in mind, the colostomy, mainly we doing temporary basis or the permanent basis. Permanent basis colostomy means we need to get the patient have the idea about or have the acceptance, need to continue the colostomy or with the ostomy only, they need to continue their life till his or her death. So they need to take proper care about the stoma. Colostomy means they can improve their or they can maintain the quality of their life till his or her death. So main challenges have need to get for the patient. One is the peristomal excoriation. If the poor skin care, if the patient is maintaining means or getting means, it will cause the skin excoriation. It will decrease or it will affect the quality of life of the patient with the stoma. So proper skin care and proper usage of bag with accurate size can prevent the getting contact on the peristomal region with the leakage from the stoma. Because of that, we can prevent the skin excoriation. So proper skin care is very important. At any time when excoriation is happening means also proper management with the already mentioned caraya powder or zinc oxide, anything they can use it and do the management and they can improve their quality of life. Then one thing also, suppose sigmoid colostomy, already we discussed. If any patient already having any sigmoid colostomy means we can tell the option colostomy irrigation only for the sigmoid colostomy. So already we discussed about on case scenario. In that case scenario, you already seen the executive only having the official jobs in between the changing of the colostomy bag. That option only actually he had, but it's very difficult for him to management mainly in the official time. So they can have another option only the irrigation. That thing also we can educate to the patient. They can continue and it will also improve the self-esteem according to the professional basis. So in palliative care, mainly we giving all aspect we will think about in palliative care, not only the physically, socially, spiritually, psychologically, every aspect we thinking about and we will managing the patient. So here the colostomy is not only the physical base, not only in physical basis, psychologically and other aspects also maybe the patient and the family will affect due to the colostomy. So proper even some points we discussed. So at any time any counseling psychological support more explanation about the care
Yes,
and
sir.
the
I
follow.
also have discussion points I
Yeah,
forgot to mention. If you allow, then can I speak?
yeah. Oh, sure, ma'am. You can.
Skin care of the patient, then cleaning the pouch regularly with soap water, and
Yes.
maintaining the hygiene of the patient, giving psychological support to the patient and family members also. Focus on the diet of the patient and uh, self care of ostomy.
Okay.
Yes, sir. Thank you, sir.
Okay.
Our facilitator Shiva ma'am has joined.
Yeah,
Okay.
yes. Yeah. Thank you, Sajan, for the wonderful session, and thank you, sister, for representing this wonderful patient story.
Thank
So
you,
I would
ma'am.
like to know about what kind of colostomy, what is the type of colostomy this patient has? Either transverse colostomy, sigmoid colostomy, or what kind?
Sigmoid colostomy.
So yeah, so if there is a sigmoid colostomy, as Sajan said, there is an option called colostomy irrigation. You can talk to the patient and the family about this. If they are
Yes,
willing
ma'am.
to do it, this is the good option for them.
Yeah, okay, ma'am.
The
Definitely, I will ask.
okay, so another thing I would like uh,
Ma'am, your voice is breaking. Shiva ma'am, your voice is
management
breaking.
and peristomal you manage the peristomal skin reaction. Hello,
Now
now
it's audible, ma'am.
peristomal skin reaction. How did you manage the peristomal skin reaction? Uh,
Ma'am, it's
sister,
breaking from your
my
side.
question is clear. Uh, yeah, Saj, yeah, Sangeet, am I audible?
You're audible, ma'am. Sometimes it's breaking. The question is not clear actually. Can you put it in the
Okay,
chat box, ma'am?
so my question is regarding the peristomal skin reaction. What about now? Is it clear?
Is it clear now, ma'am?
Okay. So my question is regarding the peristomal skin reaction. How did you manage? I am asking to her, how did you manage the peristomal skin reaction?
By applying cream, zinc oxide and karaya ka powder also we can apply.
Okay.
Yes, ma'am.
And the next question is regarding constipation.
Yes, ma'am. We
Is
can
it
do
relieved now
the
or
irrigation,
still?
sigmoid irrigation, colon irrigation also.
No, no, no. How did you manage? Still the patient is having constipation?
Then give him lukewarm water to drink.
Okay, my question is, this patient constipation is relieved or still the patient is
No. The
complaining with the constipation?
constipation
High
relieved.
fiber diet recommended to high fiber diet.
Okay, now the constipation is relieved, right?
Yes, ma'am. Yes, ma'am.
Okay, thank
The
you.
patient is
Yeah,
better now
thank you,
and
thank you.
discharged
So,
also.
okay, so yeah, when a patient done with colostomy, we all know that whenever the bowel is moved, fecal matter will come out. So this they will be managed with the help of a colostomy bag. This will be affecting the patient as much as the family, as well as the patient, to give a total care to the patient and their family. As Sajan said, always you have to do the proper assessment. If possible, you can do the individual assessment and give a holistic care to the patient.
Yes.
And also, you have to think about the sexual history. Also, you have to assess the after building a good patient relationship.
Ma'am, your voice is breaking, not audible.
Then you can these issues also proper counseling and what about now?
Yes, ma'am.
Yeah, so I was saying like sexual history also. It is important to assess the sexual history and give a proper counseling and make sure that you can give a total care to the patient and their family.
Okay, ma'am. Okay, ma'am.
Okay,
Okay, ma'am.
thank you.
Thank you.
Sajan, over to you.
Okay, thank you for the discussion. I think everything is clear. Any doubt means also now within time you can put it in the chat box. We can move through that.
One question was there in the chat box, Sajan.
So it's actually truly under the suggestion from the surgeon only.
Actually, the question is not clear. Please ask again. Need a little more clarity. So, which hole they are asking? Just ask him.
Sir Kriti, can you explain the question once more?
So when the patient is discharged after the tracheostomy, the hole it is covered with anything or we left it like this only?
No, it's already the hole is tracheostomy tube is there. With the tracheostomy tube only we are discharging. They need to continue with the tracheostomy tube. So for that tube only we discussed outer tube, inner tube is there. So in between inner tube need to change or clean after cleaning, washing, we need to reinsert without a single droplet. So the tracheostomy tube will be there on the stoma.
Okay, sir, but one patient comes in the hospital daily for suctioning that hole and no tube is inserted in that.
Usually, uh, usually there is a temporary tracheostomy there. So if there is a permanent, the tracheostomy tube will be inserted. So the opening will be always open. Because one, as Sajan said, one outer tube, one and one inner tube is inside the tracheostomy all the time. So we need to train the caregivers and patient about the care. They can remove the sorry, my voice was breaking, I think. Now, is it clear?
Yes, ma'am. It's now audible.
Hello?
Sister,
Yes, ma'am.
Yeah. Okay. Uh, I think I have received a call, so might be disconnected. So, if there is a permanent tracheostomy, that open the tracheostomy hole is always opened. So there is a inner tube and outer tube will be there. So you have to train the patient and caregiver about the changing of inner tube. As Sajan explained earlier, you can train the patient and family about changing the inner tube, but always the opening will be there. So I don't know how did you do the tracheostomy suctioning without a hole. Sajan, any other points you want to add?
sir, I think it's clear. What about
Okay.
sister?
Yes,
And
ma'am. Thank you.
and all, yeah, yeah, always try to cloth like a stoma protector or anything, so that we can prevent to dust entry, and also you can prevent to the insects entry. So these all things you can prevent if you can put a wetted wet like netted clothes inside in front of the tracheostomy area. Okay, so that all things you can tell the caregivers and patient.
Okay,
Okay,
ma'am.
thank you. Thank you.
Okay, thank you, sister. Thank you, Sajan brother, for your wonderful presentation. Thank you, sister Karthi, for presenting the case presentation. Thank you, Shiva sister, for facilitating. Thank you, everyone, and thank you for all clearing all the doubts. Thank you, everyone, for participating. Thank you. Let's see you in the next session. Bye.